Thank you for coming on board. I'm Sharimila. Well, Valerie has given a brief introduction, but that's good enough, I guess. Yeah. So I'm practicing in Colombia, Asia as a consultant internal medicine physician. Yeah. So I'm here today. I thought that sexually transmitted disease are something that, general practitioners and you guys can manage out there. So I'm thinking, why not? Yeah. Let's sit back and let's see what I can have you guys know on the updates. Yeah. Right. So the topics to be covered would be the introduction of STD management, syndromic management for major STD syndrome, and antibiotic resistance. So as you all know, sexually transmitted disease previously was known as sexually transmitted infection, but they've changed it to disease now because it's rather not almost like a syndrome. Yeah, infections that are passed from one person to another through sexual contact. Well, it is also from sexual intercourse, vaginal, anal, as well as oral sex and by just kissing. Yeah, so these are the fast facts that I could bring your attention to. Chlamydia, we have seen an increased number of cases from up to 1.8 million cases, 19% increase since 2014, and gonorrhea, 583,000 cases, which is 63% increase since 2014. Primary and secondary syphilis is about 35,000 cases, 71% increase since 2014, and congenital syphilis, about 1,000 cases, and that's about more than 100% rise since 2014. What's alarming is that, congenital syphilis and newborn deaths from syphilis has risen to 22% in 2018. So this is from Malaysia, yeah. They've collected a little of the data for gonorrhea and syphilis, yeah. Over the years, from 2009 to 2014, as we can see, there's a rise in the gonorrhea cases that's been reported up to 1,769, and syphilis is about 1,689. What's alarming is that in 2018, sexually transmitted disease cases reported throughout Malaysia has increased from 2014 to now to gonorrhea 3,130, syphilis 3,000, AIDS about 919, and chancroid, the little one here, it's about 4 cases being reported. So is there any difference between sexually transmitted disease between man-to-man sexual intercourse and non-man-to-man? Yeah. So the number of cases this was a study that was done in Hospital Kuala Lumpur. So they realized that the number of cases among men-to-men, be it syphilis, gonorrhea, and herpes simplex and Hep B, has been increased in the man-to-man transfer. Yeah. So syphilis is about 18% as compared to 3% in non-man-to-man contact. Yeah, gonorrhea 3% and non-man-to-man transfer is about 1%. So as we all know, the type of sexually transmitted disease can be divided into bacterial, viral, parasitic, and anthropod. The most common ones are gonorrhea, chancroid, syphilis, lymphogranuloma venereum. Yeah, viral most commonly is genital herpes simplex, genital warts, and HIV. And parasitic will be trichomoniasis. Hold on, yeah. Right. So what is easier now is to look at it as a syndrome, yeah. So when you say genital ulcer, if the patient comes in with genital ulcer, in the back of your mind, you should think about herpes simplex, chancroid, syphilis, LGV, which is lymphogranuloma venereum, and granuloma inguinale. Urethral discharge, most common these days, is Neisseria, gonorrhea, and chlamydia. Vaginal discharge, vaginitis, trichomoniasis, candidiasis, and cervicitis, which also includes gonorrhea and chlamydia. Scrotal swelling would be gonorrhea and chlamydia. Inguinal bubor, LGV, and chancroid. Lower abdominal pain, which is pelvic inflammatory disease, is also one of the most common. So it's rather small, but basically this is what they've thought about ever since 1997. So, when you have urethral discharge, when a patient comes and complains of urethral discharge, you examine the patient's genital areas, especially for female and male, And if you see this discharge to be positive, yeah, so you must think, oh, I should treat for gonorrhea and chlamydia, yeah. Immediately educate the patient, counsel if needed, bring in the sexual partner, yeah, or, talk to them about how important it is to treat their partners as well, yeah. So eventually, the urethral discharge, you would take a urethral swab, yeah, and you'll send it for test under the microscope, and you would get results, yeah. So they will look for this intracellular diplococci pattern, yeah. So genital ulcers, again, examine if the ulcers is if it's just ulcers, then you should think about syphilis and chancroid. If it's vascular, or could it be recurrent, so you might think about herpes simplex. Oh, skip. Yeah. So scrotal swelling, the patient might tell you that they have scrotal swelling. So when you examine, if it will confirm swelling and pain, yeah, then we think about gonorrhea again and chlamydia. They commonly cause scrotal swelling. Inguinal bulbar, if the ulcers are present and also there's inguinal lymphadenopathy, then you might consider LGV, yeah. For vaginal discharge, yeah, there's a whole list, yeah. For it could be trichomoniasis, candida, or just chlamydia and gonorrhea. So down the pathway again, lower abdominal examination and genital as well. If you can, perform a bimanual vaginal examination, yeah, and then you take the vaginal swab. Okay, let me dive into chlamydia. So as we all know, chlamydia, we can divide it into chlamydia trachomatis, chlamydia pneumoniae, and chlamydia stachyi. Yeah, the serovars that are important for sexually transmitted disease is serovars D to K and serovars L1, L2, L3. D and K, D to K will be urethritis, pelvic inflammatory disease, as well as for neonates, pneumonia and conjunctivitis. Serovars L1, L2, and L3 causes lymphogranuloma venereum, yeah. So chlamydia trachomatis, the commonest bacterial sexually transmitted infection, and the prevalence is highest in persons aged less than 25 years old. Asymptomatic infection is common among both men, 50 to 60%, and women, 50 to 70%. Common presentation, vaginal, urethral, anorectal discharge, dysuria, arthralgia, symptoms, and also pelvic inflammatory disease in women, and epididymoorchitis and prostatitis in men. So here, what is recommended is the non-culture diagnostic techniques such as nucleic acid amplification tests. Yeah, lack of or inadequate treatment risk, possibly ascending infection and further complication, as well as possible spread of the infection to sexual partners. These are the symptoms of chlamydia. Penile discharge in men, burning and painful urination, and testicular swelling. Don't forget about the scrotal swelling, yeah? For women, vaginal discharge, burning and painful urination, they might have bleeding between their periods. This is what it will look like, yeah? The discharge, yeah? It's pretty thick and core. These are the effects of chlamydia if it's not treated, yeah? It causes the buildup of the and scarring of the fallopian tube, and it prevents fertilization. That is why it is so important for us to diagnose chlamydial infections in the female. Yeah, it also causes infertility in long term. So the investigation, again, the gold standard will be and your NAT. Yeah, they are highly sensitive and specific and suitable because it's non-invasive. Yeah, gram stain, you could see an increase in polymorphonucleosides, average of more than 5 per high power field in urethral smears, and more than 20 per high power field in endocervical smears. Yeah, more than 10 in the first void urine. All right. So the sensitivity of NAT would be 87 to 98%, but it's rather specific. It's 98 to 100%. Yeah. Consider pharyngeal or rectal swab depending upon sexual exposure. Cell culture, again, is the gold standard, but it's not recommended for routine use. Treatment for chlamydial infection, uncomplicated, urethral, rectal, pharyngeal, the recommended would be doxycycline, 100 milligram 2 times per day for 7 days. The alternative would be azithromycin, 1 gram single dose, and then 500 milligrams OD for 2 days. Yeah, previously it's only 1 gram single dose, but they've changed it to add on 500 milligrams for the next 2 days. In pregnancy, azithromycin per oral 1 gram single dose is acceptable, but followed with 500 milligrams of azithromycin OD for the next 2 days. In pregnancy, if they're unable to tolerate azithromycin, you can have an alternative choice, which is amoxicillin, 500 milligrams 3 times a day for 7 days, or our famous EES for 800 milligrams, but it's 6 hourly for 7 days. So when we're treating chlamydial infection in our patient, we need to advise them, very, very important, mostly gone off without being said, to avoid unprotected sexual intercourse for a week following treatment. Yeah, partners need to be treated as well. Test of cure is not routinely recommended, yeah, but if the patient is pregnant and there is persistent symptoms or non-compliance, ideally between 4 to 6 weeks post-treatment with NAT tests. Partner notification, so trace back the history. Symptomatic partners should be tested in the last 6 weeks and asymptomatic partners in the last 6 months. Partners should be treated for chlamydia even though they are asymptomatic. Next, we go on to gonorrhea. Yeah, gonorrhea is commonly patient presents with urethral or vaginal discharge. Asymptomatic infection can occur, women more than men. Urethral discharge could be 10%, but rectum discharges can be about 85%. Women, endocervix discharge about 50%, and rectum discharge, it's about 85%. Again, culture is the gold standard, but the sensitivity is 60 to 70%, but it has 100% specificity. NAT detects the DNA of Neisseria gonorrhea. Sensitivity and specificity is pretty good, see 95 to 96%, and specificity is at 99%. Yeah. Gram stain, urethral, cervical, or rectal exudates. Yeah, looking for the intracellular diplococci in leukocytes. Yeah. Gram stain is not appropriate for pharyngeal specimens. The sensitivity is 95% for symptomatic male patients and 50 to 75% for asymptomatic patients. Specificity is 99%. Female, the sensitivity of this test is 45 to 65% and specificity is about 90%. So what's alarming about gonorrhea is that there is a potential health and economic impact of antibiotic resistance. Yeah. So if it's untreated, gonorrhea can cause health problems such as, the higher chance of them getting HIV, yeah, as well as spreading towards pregnancies, vertical transmitted to the childbirth, yeah, and infertility, pelvic inflammatory disease, and disseminated gonococcal infection. So antimicrobial resistance, we're seeing it more, particularly in gonorrhea, yeah, because there's an increase over the years and has reduced treatment options. Current gonococcal AMR surveillance program, GASP, has shown high rates of quinolone resistance, increasing azithromycin resistance, and emerging resistance of extended spectrum cephalosporin. So this is our last line treatment. The emergence of decreased susceptibility of gonorrhea to extended spectrum cephalosporin together with AMR already shown to penicillin, sulfonamides, tetracyclines, quinolones as well, and macrolides, yeah, making gonorrhea a multi-drug resistant organism. AMR for other STI, though less common, also exists, making prompt treatment critical. Drug resistance, especially for gonorrhea, is a major threat to reducing the impact of sexually transmitted diseases worldwide. So they talk about antibiotic resistance way back in 2006. The graph here is saying that gonorrhea cases with resistance to Cipro is already rising. Yeah, so We will talk about it because there's rising concerns in the US as well, yeah? And it's the second most commonly reported infectious disease, and we are only down to one recommended effective class of antibiotic to treat it. So we need to work together and we need to stop it. Yeah, basically it's because what's important is recognizing the symptoms and actually performing the investigations and giving the correct treatment. Yeah. So this is the historical trends in drug resistance and Centers for Disease Control. CDC has listed out a bunch of antibiotics over the years, and it comes down to 2015 here. Ceftriaxone plus azithromycin is the only recommended treatment for gonorrhea. So again, let's look into our national antibiotic guidelines and follow local protocol. Yeah, always culture, pre-treatment, partner screening, and treatment is very important. So treatment of uncomplicated gonorrhea, dual therapy, yeah, IM intramuscular ceftriaxone plus 1 gram of azithromycin, yeah. We add the azithromycin because it's a synergistic effect reducing cephalosporin resistance. The dose of ceftriaxone used to be at 250, but it's increased now to 500 milligrams, yeah, following development of resistance in other regions. If there's a problem with beta-lactamase allergy, we can use IM gentamicin 240 milligrams plus 1 gram of azithromycin. This can be used safely. Ceftriaxone and azithromycin can be used for pregnancy and breastfeeding. Patients must avoid unprotected sexual intercourse with their partner for a week and get their partner to be treated as well. Asymptomatic partners should be treated. Yeah. Partner notification, symptomatic partner past 2 weeks and asymptomatic partner past 3 months. Yeah. Test of cure with NAT is post-treatment is recommended. So we should call the patient back and we should schedule them for a repeat test. The case of disseminated gonorrhea, yes, preferably to get them admitted. Yeah, we will start them on intravenous ceftriaxone 1 to 2 grams a day for 7 days, and the alternative regimen would be IV cefotaxime 1 gram TDS for 7 days. If the symptoms improve for the next 24 to 48 hours, we can switch it to oral ciprofloxacin 500 BD. If you guys have sexually transmitted diseases that you think fits nothing of gonorrhea, but you just want to cover, you can try with oral doxycycline 100 milligram BD for 14 days. The other thing that is common in male patients is epididymitis and epididymoorchitis caused by gonorrhea and chlamydia. So intramuscular and IM ceftriaxone 500 milligrams step 1 dose would be adequate. Non-gonococcal urethritis is another common one. You can treat them with doxycycline 100 milligrams twice a day for 7 days for the first episode. If they come back having this, which is recurrent, then add on azithromycin 500 stat and 250 milligrams OD for 4 days. You need to add on with metronidazole for 400 milligrams twice a day for 5 days. The alternative to this would be azithromycin 500 mg stat and 250 milligrams OD once a day for 4 days. But this is for the first episode, and if it's recurrent, might consider moxifloxacin 400 milligrams once a day for 10 to 14 days, plus metronidazole 400 milligrams BD for 5 days. So the next would be syphilis. Right. So syphilis is a common sexually transmitted infection caused by a spirochetal bacterium. Clinical presentation is often asymptomatic but can manifest in a number of ways. Diagnosis is usually straightforward after clinical examination and serological testing. Treatment is with penicillin. Untreated syphilis facilitates HIV transmission and causes considerable morbidity such as cardiovascular and neurological diseases. So syphilis can be divided into congenital and acquired. In acquired, there will be early syphilis and late syphilis. Yeah, the early syphilis subcategorized into primary, secondary, early latent, and the late will be your tertiary, which includes your neurological, cardiovascular, gummatous, and late latent syphilis. So if you look at the course of the untreated syphilis, natural history, when you get your first exposure, 9 days to 90 days would be primary syphilis. Eventually, it will go on to 6 weeks to 6 months, entering into secondary phase here for the first 2 years, and eventually early latent, where the patients might or might not have symptoms. After 2 years to a lifetime, it goes into the late latent syphilis phase. So we see patients, about 14% of them having cardiovascular complications, neurosyphilis about 12%, gummatous formation 14%, spontaneous cure 30%. So patients are asymptomatic and non-infectious after the first year, but may relapse. 1/3 will convert to seronegative status, 1/3 will stay seropositive but asymptomatic, and 1/3 will develop tertiary syphilis. So in your primary syphilis, you get chancre in the shaft of your penis, and also you can get it in your lower and upper lip. It is the portal of entry, and the ulcer is painless, firm and indurated, highly infectious ulcer. It can occur 10 days to 3 months after being infected by Treponema pallidum. There will be enlarged lymph node bilaterally, but it's painless and it can persist for months. It can disappear spontaneously without treatment after 4 to 6 weeks. Secondary syphilis, as you can see here, it's symmetric mucocutaneous rash, which either it can be macular, papular, papillosquamous, or pustular lesions with generalized non-tender lymphadenopathy. In moist skin areas such as perianal and vulvar areas, papules become superficially eroded to form pink or whitish condylomata lata. They can have constitutional symptoms. They can feel weak, tired, eventually have weight loss. Spontaneous disappearance within weeks or months, followed after a latent period by the third stage. So tertiary, again, cardiovascular, neurologic, gummatous formation, and orthopedic, even eventually Charcot's joint and osteomyelitis, and also involves the kidney, causing membranous glomerulonephritis. So the investigations, dark field examinations to detect Treponema pallidum directly from the lesion exudates or tissue are the definitive method for diagnosing early syphilis. A presumptive diagnosis of syphilis requires use of 2 tests, non-treponemal test and the treponemal test. So VDRL, Venereal Disease Research Laboratory, or rapid plasma reagent titers generally rise and fall in response to Treponema pallidum infection and treatment, respectively, and usually return to normal or negative following treatment, although some patients might remain serofast and have persistent low positive titers. The treponemal test, which is the FTA, fluorescent treponemal antibody adsorb test, the passive particle agglutination assay, and EIA, as well as the chemiluminescence immunoassays and immunoblots or rapid treponemal assays can be done. But the common ones, I think, is the FTA, EPS, and TPPA. Usually yield persistent positive results throughout the patient's life following infections with Treponema pallidum. And the treponemal test titers do not correlate with the disease activity or treatment. So we usually don't, once the treponemal test is positive, we don't repeat it. We do the VDRL titer to monitor. So syphilis treatment, in early syphilis, which is your primary, secondary, and early latent, they will require a single dose of IM benzathine penicillin 2.4 mega units. It's a grade A 1B class 1B. Or procaine penicillin G 600,000 units IM daily for 10 days. The alternative therapy, if the patient has penicillin allergy, would be oral doxycycline 100 milligrams BD for 14 days. Late syphilis, benzathine penicillin 2.4 mega units IM weekly, but this is for 3 weeks, meaning 3 doses. Or the alternative would be procaine penicillin G 600,000 units IM daily for 17 days. All right. This is from our local guideline, yeah. So it's the same thing that they say that primary, secondary, and early latent syphilis, just one dose of benzathine penicillin. Okay, but look out for possibility of penicillin reaction, Jeffrey's hemisphere reaction, and anaphylactic reaction. And then if they do have that, you run a test dose, you might switch to oral doxycycline. Yeah, do screen them for HIV, and all sexual partners should be brought in and hopefully investigated. Yeah, so partner notification would be for symptomatic patients with primary syphilis for 3 months, and the others would be 6 to 12 months. So these are the alternative regimen by the CDC. It says that we can treat with ceftriaxone for 10 days, 500 milligrams, or doxycycline, like mentioned, or erythromycin stearate, 500 milligrams QI 6 hourly per oral for 14 days. EES 800 milligrams 6 hourly for 14 days as well, or a single dose of azithromycin 2 gram. Late syphilis, again, the alternative would be doxycycline 100 milligrams twice a day for 28 days. Yeah, erythromycin stearate 500 milligrams 6 hourly for 28 days, and EES 800 milligrams 6 hourly for 28 days. Okay, so this is the repetition again. Yeah, just paying attention to neurosyphilis. Neurosyphilis, if you have patients coming in with headache, feeling lethargic, yeah, as well as some of them could have fitting episodes at home. Yeah, do send them in. They need to get admitted. Yeah, they would require benzyl penicillin. Yeah, for intravenous benzyl penicillin for 14 days, or procaine penicillin 2.4 mega units intramuscularly. Yeah, with penicillin allergy, we'll change them to we'll use IM or IV ceftriaxone 2 grams per day for 14 days. Then the lumbar puncture and the CSF examination will be done. So asymptomatic contact, there's patients, sexual partners that are asymptomatic. We still prescribe IM benzathine penicillin 2.4 mega unit in a single dose, and the alternative would be doxycycline 100 milligrams per oral for 14 days, or azithromycin 1 gram single dose. So syphilis in pregnancy, screening is done at booking, and it's repeated at 28 weeks. Reactive RPR and confirmed with TPA. Penicillin regimen is appropriate for women's stage of syphilis is recommended. Yeah, doxycycline and tetracyclines are contraindicated in pregnancy. Erythromycin should not be used because of high risk of failure to cure the fetus. Monthly and clinical serological examination till delivery, and then after follow-up is as in non-pregnant patients. Yeah, so this is the patients with primary, secondary, and early latent. So patients in first and second trimesters up to 27 weeks, yeah, benzathine penicillin, IM 2.4 units, single dose can be used. Up to third trimester from 28 weeks onwards, again, IM benzathine penicillin 2.4 units weekly for 2 weeks. Yeah, you also can give per oral medication, azithromycin 500 milligrams once a day for 10 days, or EES 800 milligrams per oral for 14 days. Yeah. So when do we repeat the titers? To repeat quantitative non-treponemal serological testing like VDRL and RPR, yeah, it says repeat it at 3 months or 6 months or 12 months. Seropositivity is achieved in majority of the patients with primary syphilis by 12 months after treatment, and in those with secondary syphilis, 24 months. Seroconversion is more rapid after therapy if the duration of infection is short and the initial titer is low. So when they come in earlier and with the lower titer of RPR and VDRL, seroconversion to negativity might be rather rapid. But as the seroconversion is slow, process requiring months to years, the rate of decline is a better indicator of therapeutic response. So latent disease without syphilis. Non-treponemal tests are monitored at a 6-month interval. Yeah. So without neurosyphilis, a fourfold decrease or seronegativity within 24 months after treatment. Low titers will persist in approximately 50% of the patient with late syphilis after adequate therapy after 2 years. Yeah, the low titer persistent seropositivity does not signify treatment failure or reinfection, and these patients are likely to remain serophast even if they are treated. So without neurosyphilis, a fourfold decrease, we should monitor for a fourfold decrease, yeah, within 24 months. The FDA apps is not recommended because it is always positive earlier and remains positive longer than VDRL. And also it picks up positive results for Treponema pretinu. Yeah. In patients with neurosyphilis, VDRL CSF is repeated 4 to 6 months interval. If the CSF pleocytosis or CSF VDRL titers are noted initially. Some experts recommend that HIV infected patients be followed more closely at 3 months interval. So when is it treatment failure? Yeah, it is treatment failure if there is persistence, recurrence, or development of clinical signs of symptoms of syphilis in the absence of reinfection. Sustained greater than 2 weeks, fourfold increase in non-treponemal titers, assuming that the same test was used. Yeah, if there's an increase in fourfold, yeah, then we might think of treatment failure. Failure of initial non-treponemal tests to decrease fourfold by 6 to 12 months for primary and secondary and early latent syphilis, and by 12 to 24 months for late latent syphilis. Yeah. So if we have a patient that has a titer of 1 in 64 or 1 in 32, do not repeat them in the next 1 month. At least, take time to repeat either in 3 months or 6 months. Yeah, and it can even be longer for late latent syphilis. Yeah. So genital herpes is an STD caused by 2 types of viruses. Yeah, the viruses are called Herpes Simplex 1 and Herpes Simplex 2. Okay. So again, HSV PCR, higher rate of HSV detection could replace viral culture as the gold standard for the diagnosis of genital herpes in people with active mucocutaneous lesions. Yeah. So the lesions are usually painful and vesicular. Alternatively, antigen detection and immunofluorescent tests or enzyme immunoassay for samples from the symptomatic patients. Treatment will be with oral acyclovir 400 milligrams 3 times a day for 5 days, or oral valacyclovir 500 milligrams twice a day for 5 days. So you have to start treatment within the first 5 days of onset of lesion. The patient would require a little bit of some analgesics and some local anesthesia and saline sitz bath as well to go with. This is showing that the HSV DNA has the highest specificity and sensitivity, yeah? As to compare to those days, cytological examination, sang smear has very, very low specificity and sensitivity. Yeah, so more towards the HSV DNA, NET PCR is preferable. So recurrent herpes will be short course of oral acyclovir 800 milligrams for 2 days, yeah, and or a 5 days course regime, oral acyclovir 400 milligrams 3 times a day for 5 days. Alternatively, if you have oral valacyclovir 500 milligrams twice a day, 3 to 5 days. Herpes genitalis suppression therapy, patients might come back with more than 2 or 3 episodes, but more than 6 recurrent episodes, oral acyclovir 400 milligrams BD or oral valacyclovir 500 milligrams OD for a year. Yeah, topical antiviral is not recommended. Yeah, because there is association with acyclovir resistant strains. Herpes genitalis in pregnancy in the 1st and 2nd trimester until the 27th week. Oral acyclovir 400 milligrams 3 times a day for 5 days, or valacyclovir 500 milligrams twice a day for 5 days. Do not delay treatment. If clinically you think that the patient has herpes genitalis in pregnancy, do treat the patient. Third trimester from 28 weeks onwards, oral acyclovir 400 milligrams TDS for 5 days. For suppressive therapy for recurrent, continue oral or recurrent, continue oral acyclovir 400 milligrams TDS starting from 36 weeks onwards until delivery. Yeah. Okay. This one as well, because we've seen in the early statistics, there's about 4% of the patient, 4 patients that were picked up. Yeah, chancroid caused by Haemophilus ducrei, easily treated. Yeah, painful ulcers, once again in the genital areas. Yeah, it's easily treated with oral azithromycin 1 gram single dose, or intramuscular ceftriaxone 250 milligrams single dose, or for HIV patients, ciprofloxacin 500 milligrams twice a day for 3 days. The ulcers usually improve symptomatically within 3 days, and reepithelialization occurs within 7 days after onset of therapy. All right, okay, so that's all that I have for you today. Thank you very much. All right, hold on. I've got a couple of questions here. So from Dr. Lim, for chlamydia and gonorrhea NET tests, what is the proper swab and transport media and proper site of swab? Yeah, can early midstream urine be used for male? Swab for female, do we swab cervix or high vaginal swab or low vaginal swab? Okay, so Lim, yeah, so usually we will swab the patient for cervical swab. Yeah, the high vaginal swab will do. Yeah, not the low cervical swab, because you will pick up other bacteria as well. Yeah, so high vaginal swab. Can early stream urine be used for male? No, it should be at the midstream urine. And what is the proper swab, proper site of swab for male? Well, if you milk the penis, the shaft of the penis, yeah, so what you can do is that you can clean the area, yeah, first before taking the swab for the male patients, and then yeah, and then when you milk the penis shaft, yeah, the urethral discharge will be coming out. Do not take the one that is already smeared outside. Clean that all up and then milk the shaft. Yeah. Next question. All right. Okay. How do Dr. Lim as well? Okay. All right. So how to conduct partner notification? Okay. Very good question. Schedule visit based on list provided by index case. Yes. So partner notification, I think it goes back to the CDC guideline was to ensure that, to trace back the partners that the patient has. Sometimes you find this very difficult, but we do. When you bring them to our clinic, we definitely talk to them and make sure that they do have the contacts. If they don't have, and then our local IK, yeah, get the names, get the patient's name, notify the patient, and I'm sure they will come back and they will get something. You'll be surprised. Yeah. Do notify. Yeah. So Dr. Tan, dear doctor, if we have a patient who has unprotected sexual intercourse, but with only erythema and pain at the glands, can we deduce any diagnosis from this? Okay, yeah. So first of all, does the patient only have one sexual partner or partners? Yeah, go back to that. And constitutional symptoms, yes. Erythema per se, no, because their common presentations will still be ulcers and discharge. Yeah, pain at the glands, yes. So for males, looking at the inguinal glands, and also do examine their scrotum. Yeah, and you might get thickening of the epididymis. Yeah, it could be epididymis or epididymoorchitis. Yeah, I heard there is another. Okay, Dr. Lim, I heard there is another approach to test triple-normal test first. If reactive, only go for non-triple-normal. Well, no. So what's my view? Yeah. So again, both. You require both tests. Yeah. You can't just do one, even though if it's FTFs and all that, you still have to do both. Yeah. Non-triple-normal and triple-normal. This is the guidelines by CDC and WHO as well. Yeah. So go for VDRL. VDRL negative, perform the triple-normal test. TPHA. Yeah. For foreign worker screening, VDRL test is done and if it is positive, he is unsuitable to work in Malaysia. Okay, VDRL can also be positive. Exactly. Yes, VDRL also can be positive in other cases. That's right. That's right. Do you recommend FTFs? Yes, but you could perform either this or the TPHA. Yeah, do perform the TPHA. Okay. So for prevention of transmission to partner to herpes patient, do we advocate long-term therapy? No, we don't. We don't. Both the patient and the sexual partner, treat them with the acyclovir. Yeah. Okay. No, don't have to be for long-term acyclovir. Yeah. Yes. So, Dr. Bhupinder, thank you for your question as well. What about the preference of rectal swab in man-to-man transfer? Yes. Cases in place of first void UD. Yes. So the rectal swab, either the rectal or the urethral and the first void urine, if patient comes for screening out of fear once test is symptomatic. Yes, yeah, definitely. Yeah, the rectal swab can be done. Yeah, it's either the rectal swab or the urethral swab or the urine. All right. So thank you very much. Yeah. So I'll pass it back to my executive marketing, Valerie.